Yes, we can hear you, Dr. Very well.
All right, thank you very much. Just to give me some time because there's some technical difficulty where I cannot share the PowerPoint presentation. So as soon as it is resolved, we will be starting the session, okay? All right. You people can see my screen?
Hello, Dr. Rosma. I was in the OSCE course, but I deferred the exam because of the war in Sudan.
Ah, yeah. Okay, all right. Okay. Anyways, just to, give you a brief idea of those who will be sitting for the first time that, as you know, MRCPI OSCE, there is one long course and 7 OSCE stations. Long course is for about 30 minutes and 25 minutes, sorry. And then after that, in that 25 minutes, 10 minutes are there for your history taking information gathering. And the remaining 15 minutes are for examination and then discussion with the examiner. There will be 2 examiners who are sitting at the backside of the simulated patient. They will be observing and listening to whatever you are talking to the patient. So if you have left anything in the history, don't, make a story from your side that this is what she said. Just said, okay, sorry, I forgot to ask her this question. Okay, because they are listening to each and everything. Once you are done with the history and information gathering, they will ask you to examine the patient. Not the patient, actually, it's the mannequin. If it's an obstetric case, you are expected to verbalize the general physical examination and then do a abdominal examination, okay? And if it is a gynae case, they want you to just verbalize both general physical and abdominal. Sometimes they want you to do it. Although in my case, gynae case, only the pelvis was lying there, so there was no abdomen. So they wanted me to say what I will look for in abdominal examination. And you are supposed to do a vaginal examination, speculums. The pap smear is also toolkit is there. If they ask you, you have to, collect pap smear for the mannequin. And then they set and they ask you what is your diagnosis, what is your differential diagnosis, and then the management plan. In RCPI, there is very minimal information which is available for you to read once you go inside. And everything you have to ask. It looks as if it is you are taking the patient from the scratch. Although the patient will be having some investigations already with her, but she will not tell you unless you ask for it. Because I did not, there was nothing on my exam table, only few lines that patient is this many years old, came with postmenopausal bleeding. That is all. Once I did all information gathering and everything, then I asked her, did you do any investigation? Then she showed me the ultrasound report she had. So, unless you ask for it, they will not provide you. And they will say, okay, you will ask what all labs were done. Then the examiner will ask from backside what investigations you want. So if you have like a list of investigations like a CBC, CRP, any tumor markers, any imaging techniques, so you will verbalize, and then they will give you the report. Okay, if you want a histopathology, sometimes the patient has already done hysteroscopy and endometrial biopsy, but nothing will be mentioned in that station. So you have to ask for it, and if it's done, they will give you. So with that, it goes onwards. Okay, am I clear so far? Any questions about this? All right. So who would like to take this station today? And then we will be discussing the new updated guideline for the postmenopausal bleeding. Anam, Inas, anybody want to take? You want to volunteer? Come on, guys. Girls. We have so many people who want to come and take the station.
Hello, ma'am.
Who's this? Speak louder, please.
Yes, ma'am. I'm Dr. Ruma.
Okay, Dr. Ruma. So you would like to take the station?
Yes, ma'am, but I don't have much idea, so but I can try.
It's okay. It is just
Yeah.
a practice session. It's a webinar. It's not exam, so no worries. Okay?
Okay, ma'am. Okay.
All right. So you are MRCPI student. Just I want to confirm because otherwise, the people who are going for MRCOG, they are going in a different direction. So I just want to confirm.
Yes, ma'am.
All right, good. All right. So, we will be taking it as a long case, but just the examination part we will omit. But you have to finish it in. So examination, I will keep it for, say, 5 minutes. All right. So you have 20 minutes to perform this task. Okay. In the real exam, 10 minutes, they knock at the door that the 10 minutes are gone. Okay. Then the examiner asks you to proceed for the examination. So you make sure that you finish your history taking in 10 minutes. All right.
Okay.
Okay. There is no 2-minute reading time like MRCOG. So once you enter the cubicle for the exams is already, it is started. So please, that all time is yours. You want to take 15 minutes, 20 minutes history, that is also your time. You want to finish the history in 10 minutes and then leave the remaining 15 minutes for examination and case discussion, that is also your choice. Okay. My suggestion is don't leave too much time for case discussion. Don't be in a hurry because the more time you have there, then new things they will start asking you because there are 2 examiners. So sometimes, they get very excited and ask you all the things and then you get trapped in that thing. All right. So this is the task. Okay. Can you see the task?
Yes, ma'am.
Okay. So I've written 10 minutes, but it is not 10 minutes. Okay. You have 20 minutes to perform this task. Huh?
Okay. Okay.
I'll put the timer and we'll start the station. Okay.
Okay.
All right. Let's start.
Okay. Ma'am, should I ask questions now?
Yeah, start. You are in the cubicle. You are in front of the patient now.
Okay. Good morning. I am Dr. Ruma. I'm one of the doctors in this hospital. Can I ask you questions?
Yes, doctor.
Can I know your name? May I know your name, please?
Yeah, I'm Sophie Harman. I'm 57 years old.
Thank you very much, Ms. Sophie Harmer. Nice to meet you. I want to ask you, can you tell me for how long you have been suffering from this problem and what actually happens?
Yeah, doctor, I had my menopause 5 years ago. And then maybe 6 months, I started to have some bleeding. But then I ignored it. Maybe I thought sometimes you have some bleeding. But now it has become regular and it's bothering me. So I thought I should come and check with the doctor. So I went to the GP and they told me to go to a gynec doctor. So that's why I'm here, doctor.
Okay, Ms. Sophie, I want to ask you that is it continuous or you are suffering from in intervals, like after 10 to 15 days, or it is in the form of regular cycle?
No, doctor, it's not regular cycle. It's just coming and going. It's not regular bleeding.
Okay, Miss Sophie, I want to ask you, do you feel anything else other than this bleeding? Any other symptom? Any mass?
No, doctor, I just feel discomfort in my lower part of the tummy, as if there's continuous pain. That is all, doctor.
Okay, Miss Sophie, can I ask you that are you married? And what about your children?
Yes, doctor, I am living with my partner. I have two children. One is adopted and one I gave birth. That is, both are now, grown up. One is 28, one is 25. So yeah, my baby was born by cesarean section, and yes.
Okay, Ms. Sophie, I want to ask you, Ms. Sophie, do you have any family history of any type of malignancy in your family?
What is malignancy, doctor?
Oh, any type of cancer, Ms. Sophie?
No, doctor, not that I know of.
Okay, Ms. Sophie, I want to ask you that do you have any other problem like any breast issue, or are you taking any medications?
Doctor, I took HRT in the beginning for about 2-3 years, then I stopped it. So now I'm not taking any medication.
Okay, Ms. Sophie, all right. And I want to ask you about your weight. What's your weight exactly, if you know?
They told me it's on the higher side. My BMI is 34.
Okay, I see. Okay. And wait, okay. And have you you suffer from any disease like PCOS?
Yeah, doctor, once I was young, I always had a problem with my periods, and I was gaining weight and hair all over my body, and then they diagnosed me with PCO. They gave me some medication for some time, but then I just left it after my first baby. I was conceived, and then I said, okay. So it was never a regular cycle, and yeah, I used to ignore this PCO, but it was there.
Okay, Miss Sophie, all right. And on the have you, Ms. Sophie, I want to ask you that have you undergone any investigation, like any sort of ultrasound or blood test?
Yeah, doctor, they did some blood tests that told me the blood tests are normal, and they did perform ultrasound, and they said you will discuss the report of the ultrasound with me.
Okay, Miss Sophie. And thank you very much, Ms. Sophie. Nice to meet you. I'll discuss your report with you.
Okay, the ultrasound says bulky uterus with thickened endometrium. The endometrial thickness is 15 millimeter. No adnexal mass seen. No free fluid in the pouch of Douglas.
Okay. Now, ma'am, I have to discuss the report also.
Yeah.
Okay. Okay, Ms. Sophia, I want to tell you that I was reading your report, and it shows that your uterus have some pathology, like like its thickness is on higher side. Like Ms. Sophia, I want to tell you that the normal thickness is like 4 millimeter, but it's 16 millimeter, so it's on higher side. Are you getting me, Ms. Sophie? So
yes, doctor. I know, but what this means, I didn't get you. If it is thick, so what will happen?
okay, don't worry, Ms. Sophia. I'm here to facilitate you. I want to tell you that we will go some endometrial biopsy, like we will take a tissue from your uterus, and we will test it at what is the cause. We will go for the hysteroscopy and biopsy. It's a simple office-based procedure. and you will not feel any pain, and we will give you some analgesics also, and then we will evaluate you whether what is the cause of this problem, that why your uterus is getting thick, and is it there are two causes of these problem. Maybe it can go towards the endometrial cancer. So we will evaluate, then I'll inform you.
Okay. So, doctor, what do you think I can have? Is it something dangerous?
Miss Sophie, I can't, I can't confirm you anything before getting all the investigation done and before making it confirm. But it can be dangerous, it can't be. We are under the procedure of investigation, and I will inform you soon.
All right.
Maybe,
Okay.
yeah.
So the histopathology report is there. You have performed a hysteroscopy endometrial biopsy on her, and it comes with endometrial hyperplasia, atypical hyperplasia. So how you will manage?
Okay. Um, Hi, I'm Miss Sophie. I'm here with your report. How are you? Are you good?
Yes, doctor, I just want to know what happened. They called me to come urgently.
Yeah, Miss Sophie. Don't worry about your result. I want to tell you that it's a condition called endometrial hyperplasia with atypia. It means that you have some abnormal cells in your uterus. So you have some abnormal cell towards in your uterus, but luckily it is not a cancer. But I want to inform you that it can go towards the cancer also. But we have some type of treatment. Are you getting me?
I don't know, doctor. You are saying it is not a cancer, but it can be a cancer. So what it means?
Yeah, Miss Sophie, nice question. I want to tell you that it's a pre-malignant condition. It's a pre-malignant mean that it is the condition, it is the stage before cancer. That it can go towards cancer if we don't treat it, then it can go towards the cancer. Are you following me?
Yes, doctor. So what you will do for me?
Okay. Miss Sophie, don't worry. We are with you. We are here to help you. There is a definitive treatment of this disease, which is called the total abdominal hysterectomy. It means that we will remove your uterus and along with ovaries. So this pre-malignant condition will not become the cancer. So what do you think about this? How does it sound?
It's okay, doctor. If something that can cause threat to my life, why to keep it? So, are you sure it
Yeah,
is just inside my uterus? It is not. It will not spread, and you will not find it later somewhere else.
Miss Sophie, it's inside your uterus because we have gone through investigation and it is inside your uterus. Like you have completed your family and you are 40, 57-year old. So we will go through this procedure and you will be all right after this treatment. And I'm very satisfied that it is not a cancer and it is a pre-malignant condition, so we can treat it and we can save you from the cancer also. So you will be all right, and you will be all right. So if you
Okay,
want
doctor.
to
I don't
ask,
want to have a surgery done. So, is there any other option for me?
Miss Sufi, there is one option more for you, and we have LNG IUS. We will fit that LNG in your uterus, and then we will keep on going on biopsy. We will take the biopsy after 3 months, and then we will evaluate that it's getting better or not. Then we can inform you. If there will be regression in this pre-malignant condition, then it will be fine and okay. And if it will not go towards regression, then again the option would be the same, that we will go towards the surgery to save your life.
Okay, doctor. I will think I will discuss. Thank you, doctor.
Thank you very
Okay,
much, Ms. Sophie.
doctor.
Yeah.
Now your examination part I have omitted. Now the discussion part starts. Okay. Now you're with the examiner. Okay. So can you just summarize the case for me?
Yeah, I have one patient, Mrs. Sophie Hammer. She's 57-year-old, and she came with a complaint of postmenopausal bleeding for 6 months. And after taking history, she told me that she's obese. Her BMI is 35, and she had history of PCOS, and there is no family history of any endometrial cancer, and she has no personal history of any breast cancer. She had taken HRT for 2 to 3 months, then she stopped, and now her major complaint is only that she had menopausal bleeding for 6 months. On ultrasound, on investigation, I found that her uterus is bulky, and there is endometrial thickness of 18 millimeter, and her endometrial biopsy shows endometrial hyperplasia with atypia, and I offer her the definitive treatment, and also she asked me treatment other than surgery. So I told her that she can also go for the LNG IUS, and then we will follow her through biopsy in 3 months, and that's all.
Okay. So what is your differential diagnosis for a postmenopausal bleeding?
Ma'am, my differential diagnosis for the postmenopausal bleeding can be endometrial hyperplasia, endometrial carcinoma, any polyp, and atrophic vaginitis, and any can be any fibroid, or and maybe due to tamoxifen use, and maybe due to obese people.
Right. Okay. So you performed hysterectomy, and the histopathology report came as a stage 1B2 cancer. So now what you will do, how you will follow up the patient?
Ma'am, if the histopathology report show 1B2, I will go for the radiotherapy and brachytherapy. I will arrange the sessions of radiotherapy and ERBT.
1B2 you will arrange, okay. So what will be your follow-up plan for the patient? For how long you will follow her?
For how long? For 6 months. I don't know.
What you will tell the patient after she comes back and you discuss the histopathology report? So you have a plan for
I will
her?
tell her that, yeah, I will tell her that you will go through the some sessions of radiotherapy, and then we will follow you, and we will again test you.
Okay. Anything else you want to say?
No, ma'am.
All right. Okay. Thank you very much. You came up and you had the courage to perform this task. This is the most important thing over here. So don't worry about how you performed, because it needs courage to speak in front of public. So I really appreciate that courage you showed. So you know what actually in the real exam, you have to complete your history taking, and your history should be, very crisp. You should know exactly what you are asking. You should take everything from presenting complaint. You have to ask, how is she doing? What happened actually? Can you tell me more about your bleeding? Any weight loss? Any loss
Yes,
of
yes.
appetite? Do you feel your clothes have become thin? Any history of concern in your, do you see your GP for any reason? You did not ask her about diabetes history, although I said I'm not taking any medication, but you have to ask
Yes,
directly
ma'am.
because the risk factors, PCO was there in your mind, but there is another risk factor. Obesity was there in your mind, but diabetes you did not ask. Plus, once you are done with the history, past history, surgical history, and then family history, any drugs is she taking, any allergies to the drug? Did you have any pap smear done? Was it normal, not normal? How was your period before your menopause? All those things which will give you a lead towards the diagnosis. And that what investigations are done, then she will tell you that this is ultrasound which shows thickness of 15 millimeter. And then it goes most likely a case of endometrial hyperplasia or endometrial cancer. So she's 57 years old. She doesn't need her uterus anymore. So you can offer her, as you offered, that there, there can be a conservative management and there can be a definitive management. Definitive management is good for you because you have already completed your family, you have attained menopause. So it's better to remove this organ which looks to be diseased, because there is always a chance that these cells which are abnormal, they can convert into cancer cells. Although at this moment they are not cancer cells, but if we leave them behind, then they can convert into cancer cells. So it's better to remove your uterus and your both tubes and ovaries, because you have attained a menopause. We don't need your ovaries, they're already not functioning. And then once they will tell you that this staging is very important in RCPI. RCPI, it is mostly your knowledge-based exam, okay? Communication, of course, is important, but it is basically knowledge-based exam. So you should know your history very well. You should know how to investigate any complaint. If a patient is coming with post-menopausal bleeding, how you're going to investigate that patient. So from ABC, everything they will, because they're listening at the back. So if you say something, they will, if they have a report, they will give you the report and they will say why you want to do it, what you want to know in that. Okay, and then they will give you, okay, this, as I said, this only, yes, you have done the hysterectomy. Now this is the report, how you will follow. So you should have a follow-up plan. It is a confined cancer, okay? You don't need a brachytherapy and radiotherapy or chemotherapy for this patient. So you will just follow her up for up to 3 years, okay? And annually you will do a CT scan on her and you will tell her about the red flag signs. If she starts to have any further bleeding, suppose there was a CIN3 which was not corrected at that time and no treatment was done, you need to do a wart smear for her, right or wrong?
Yes, ma'am. Yes, ma'am.
Okay. So anyways, yeah, tell me.
Ma'am, I was thinking that it is the intermediate stage 1B, so that's why I was offering brachytherapy.
No. You have already removed her uterus. It is confined, so you don't have to go. This is the definitive treatment, but you have to have a follow-up plan for her. How you will follow up the patient, for how long. Okay. So anyways, thank you for, coming up and doing the task. Anybody want to ask anything before we start with the new guideline?
Ma'am, I wanted to ask you, it's not regarding the menopausal lady. There was a question like PUL, and there was a mild fluid in the pouch of Douglas. Patient is quite stable. It is query PUL or query miscarriage. It's very early. So that role player asked, so what does this mean by this fluid in the fluid here?
You mean a pregnancy of unknown location?
Yeah,
so
yeah.
I don't know. It is mild fluid. What is the significance of mild fluid? Okay. So significance of mild fluid, you just tell the patient that at this time, we don't know. It can be a pregnancy outside your uterus. Okay. Which maybe sometimes if it's a small pregnancy that ruptures, that will show a sign of, this is one of the signs with some fluid collection in the pouch of Douglas. But normally with the pregnancy which has ruptured outside the uterus, it will be associated with more pain and some changes in your general condition, like your blood pressure will be fluctuating. Your blood pressure can be low, pulse will be high. So at the moment, we will just follow up this ultrasound to confirm that there is the pregnancy sac. So we will repeat your ultrasound in 1 week time to be sure. In this 1 week time, anytime you start to have severe pain, or you feel you are not, you faint, or you have bleeding, you can always come back to the emergency. Okay?
Thank you. Thank you, ma'am.
No problem. Okay. Anyone want to ask anything about this postmenopausal bleeding case? Because it is frequently coming as a long case.
Sorry, can it be dysfunctional uterine bleeding?
Sorry, your voice is not clear. Sorry.
Can it be dysfunctional uterine bleeding? Since differentials for postmenopausal bleeding.
I didn't get you. Dysfunctional uterine bleeding and what?
Can it be a differential?
You mean this differential as dysfunctional uterine bleeding? Yeah,
Yes.
you see, dysfunctional uterine bleeding, it can be a differential among people who are perimenopausal. They are still having periods. But the person who has already crossed menopause, she was amenorrheic for a few years and now she's having bleeding. So this does not come among the differential diagnosis. Most likely, the most common cause of a postmenopausal bleed is atrophic vaginitis. Okay, this is a benign cause. Then you have any endometrial hyperplasia, endometrial polyp, endometrial cancers. But dysfunctional, you cannot say in this postmenopausal 57 years old female. All right?
Okay, thank you.
No worries. All right. Any more questions? Then we'll start with this guideline. So as you know, this guideline came in 2023, and these are the recommendations as per the RCPI. That first of all, how you define amenorrhea. So there should be a 12 months gap from your last period to call somebody is having amenorrhea or a menopause. Okay. And the women who are having postmenopausal bleeding and they are not on any HRTs, any episode which of vaginal bleeding occurring within 12 months or more after the final menstrual cycle. What do you mean by this? You understood this line?
It means that the patient had menopausal bleeding after the cessation of menopause and she is not taking HRT.
Yeah, it is actually the same. Okay. So any female who had didn't have period for 12 months is considered to be a amenorrheic or a menopausal woman. Okay. So what this suggests is to assess and identify and monitor the different identifiable risk factors for endometrial cancer. So what are the different identifiable risk factors? We all are aware of them. Can anybody just share some?
BMI more than 35.
Yeah.
And smoking. And endometrial thickness more than 4.
Endometrial thickness is something which is subjective. No, you have investigated the risk factors in the history of the patient which can lead to endometrial cancer. So what are those risk factors?
Any diabetes, high blood pressure, big BMI, smoking, then any ovarian, anovulatory cycles, then
tamoxifen use.
Tamoxifen.
Yeah, okay, that's right. So we have a list of, things which can cause which are risk factors for the development of endometrial cancer. They are nulliparity, polycystic ovaries, diabetes, obesity. So many things are there, right? So we will be discussing them one by one. Okay, so they recommend that the vaginal, vulval, and cervical cancers are also considered in the differential diagnosis. So this is something very important, that maybe there is the endometrial polyp is there, or a cervical polyp is there, or only there's cervical cancer, or there was a vulval cancer which has now spread to the uterus. So these all pelvic cancers should be considered once you are evaluating a patient with a postmenopausal bleeding. Okay, clear so far?
Yes, ma'am. Yes.
Yes, if you are right, low parity, nulliparity. Yeah. So they also recommend that urological and gastrointestinal cancers are also considered in the differential diagnosis for women presenting with bleeding that is thought to be coming from the genital tract. So that means that it can be, they also want you to think about the cancers of like a bladder cancer or a colon cancer, which has most likely, they are now here, they think that it is a metastasized cancer, which has gone to the uterus, that is causing a postmenopausal bleeding. So any patient, so they want you to have your picture should be very wide once you are making a differential diagnosis. So that is why once a patient comes with this bleeding, you don't confine yourself only to the pelvis. You always think about different other things than pelvis. Maybe it is a secondary cancer. The primary is somewhere else. Maybe it is a bladder cancer. Maybe it was a colon cancer, which are secondaries in the uterus now, and that is leading to menopausal. That can be only sign of, this cancer. Then upon investigation, you found that it is not endometrial cancer, it was a colon cancer or an ovarian cancer, which has spread to the adjacent organs. Okay. So what else they say, that women who present with the menopausal bleeding in the general practice, like they will first go to the GP. Your history should be focused and examination. So for us, patients are coming up, they are normally sent from the GP already. So they already have a history and examination done, but the exam, they want you to repeat the history, focused history. What it means by focused history?
Ask only the relevant history.
Yeah. So, there are few people who have just, they are in a habit of asking unnecessary questions and, which are not relevant in that case at all, just because somebody told them that you have to ask all these questions. So it doesn't go. You have to appear natural in the exam and take a focused history. And like in this patient, you are suspecting a cancer. So what should come in your mind once you are taking the history? Anybody can say?
Any weight loss,
Yeah.
appetite, then
Yeah.
any other shortness of breath or anything like that, then any family history of cancers, any other cancers in the past for her, then
Exactly.
any clots, history of clots, or yeah. Then how is her mental health support at home?
Mental health is of course important, but here once we are talking about history taking, then first you want her to explain her bleeding and how was her previous cycle and the relevant things as we discussed earlier. That was is she having a child before? Because nulliparity is one of the risk factor. Then is she having diabetes? So please, if she doesn't give you, direct answer, saying no, I don't have any other problem, then just ask her direct question that do you have any diabetes? Are you seeing your GP for any other problem like diabetes? Because the examiner want to hear that you have a knowledge of the risk factors for development of endometrial cancer. Okay. So
Yeah.
then what they say that after focus history examination, and you have to perform a vaginal speculum examination, and then if you're suspecting something which is beyond your scope, you refer them to the gynecological services. And they recommend that all postmenopausal bleeding patients who are not on hormone replacement therapy, they should be investigated. Okay. So all women with abnormal bleeding on HRT, they should also be investigated. So both needs investigation. But the endometrial thickness for the people on HRT and for the women who are not on HRT is different. Anybody knows how much it is?
Ma'am, on sequential HRT, it's 7 millimeter, and combined, it's 5.
Okay, anybody else want to try? 6? All right, it will come now. Okay, so they say
Continuous is 5 and sequential is 7.
All right. Okay, we'll discuss this now. Okay, so what they're saying is any woman who is coming with a postmenopausal bleed, whether she is on HRT, not on HRT, or she is on tamoxifen, they all need to be investigated. Okay, so and the investigation should be within 28 days. All right. So they suggest that whenever it's possible, these women should be referred for investigation to the ambulatory gynae clinic. Okay, whether they are on HRT or they are not on HRT, you have to investigate them and send them to an ambulatory gynae clinic. All gynae services should be able to assess and investigate the women who are with the postmenopausal bleeding. And where ambulatory services are not available, then you have to send them to a fast track pathway for these women. So since this is a new guideline, so expect all these questions from the examiner that when you will refer this patient for the fast track. So first choice is to send her to the ambulatory services within 28 days. If the ambulatory services are not available, then you have to refer them to the fast track pathway. Okay, and what is a fast track pathway? It is a 2-week referral pathway, okay? Just like RCOG. Clear?
Yes, ma'am.
All right, so now what is there? This is 4 millimeter, not 5, not 6, okay, it is 4 millimeter. So women who are postmenopausal and their endometrial thickness is more than 4 millimeter, they are the candidates for the endometrial sampling. Okay, so what you can perform just a blind endometrial sampling through a pipple biopsy, but always remember whenever there is a patient who is with risk factors, it is better to go for the hysteroscopy directed biopsy. Okay, got it?
Yes, ma'am.
All right, so this is the recommendation to go a diagnostic hysteroscopy whenever the transvaginal ultrasound shows focal pathology like it is, and the thickness is more than 4 millimeter. Like if the ultrasound is suggestive of a polyp or any abnormality seen in the uterine cavity, then it is always better to go for a hysteroscopic directed biopsy. Then even for the patient who are on tamoxifen, they have abnormal uterine bleeding, they should also go for hysteroscopy and directed endometrial biopsies, okay? Then instead of an abdominal scan, you have to go for a vaginal scan, okay? Transabdominal is only used as to complement the findings of the vaginal ultrasound. Suppose it's a big mass which is going into the abdomen, so you have to perform a transabdominal plus a transvaginal, but the initial investigation will be a transvaginal ultrasound. Okay? And what they say that some people are in the habit of just doing a direct isolated dilatation and curettage as a first line method of obtaining the endometrial samples. So they don't recommend that. Okay, it should not be used. So they do recommend the office-based biopsy, which can be used along with the transvaginal ultrasound with or without hysteroscopy. Okay, so you can perform an endometrial sampling, which is done in the office, but blind sampling as such is not sufficient for investigation. What is blind endometrial sampling?
People.
Sorry?
People sampling.
Biopsy.
People sampling, yeah. So where you are suspecting a cancer, it is not advisable to go for a people biopsy. So here what they are saying, if you want to perform a office-based biopsy, either it should be ultrasound guided or with or without hysteroscopy. Okay, so either you use a hysteroscope or you use an ultrasound to get the endometrial sample. Okay, clear? So don't go for a blind biopsy. That is not sufficient for investigation. All right. Then hysteroscopy, they always recommend to go through vaginoscope. Okay. So it is less painful and can be done easily in the outpatient setting. And then that is a different topic, what type of hysteroscope we will use in the outpatient setting. Then what they're saying that with no contraindications should be advised to take the NSAID. This we all know that before performing an outpatient hysteroscopy, you can give a non-steroidal anti-inflammatory agent like Voltaren or Brufen to the patient 1 to 2 hours before the surgery. Okay. So you should, what else they are saying that hysteroscopy and a repeat biopsy should be considered in females who experience unexplained, persistent or recurrent postmenopausal bleeding in the setting of prior reassuring investigation. You know what it means? Like, what are the other reassuring investigations before that, like a CT scan or an MRI? So if the patient is having all these postmenopausal bleeding, then you should go for a hysteroscopy and repeat the biopsy. Okay, suppose you have done just the endometrial biopsy with a transvaginal ultrasound and the patient is still having bleeding, and there is still time to do the other investigations. So you should go for a repeat endometrial biopsy with hysteroscopy. Okay, clear?
Yes, ma'am.
Okay. Then what they're saying that menopausal women without bleeding, transvaginal ultrasound is showing a thickness of more than 11 meter, it should be investigated. If it's just patient has just come to you and by chance you found out that the endometrial thickness is more than 11 millimeter and she is not having any bleeding, still she needs to be investigated. Okay. Then females who are on HRT, they are still having bleeding, they should be investigated. Then, after starting HRT, there is a possibility that females will have some sort of bleeding. But that bleeding, if it exceeds more than 3 months, then you have to investigate that bleeding. Are you getting this guideline, what it is saying? Because it will, cover the part 2 exam questions also, and they might ask you such questions in the OSCE exam itself. If it comes as just a case-based discussion with the examiner, then they will ask you all these questions. So how long you will wait for a patient on HRT is having abnormal uterine bleeding. So how long you will wait? So the answer is 3 months.
3 months.
Right? Okay. All right. And then what they are saying that if the woman is taking continuous combined HRT, they should be referred for investigation if the bleeding is beyond 6 months of commencing therapy, or if bleeding occurs after a significant spell of amenorrhea. Where additional risk factors exist, clinical discretion may warrant earlier referral. You understood that? So first 3 months, it is expected that females who are on HRT, they can have some abnormal uterine bleeding. But once it crosses 3 months, you should try to, go and investigate. And definitely, if the experience heavy bleeding beyond 6 months of commencing therapy, you have to investigate. Okay? All right. Can you see this chart, this algorithm? So here the patient comes to the GP and there is some abnormal bleeding. GP diagnosis is after a thorough history and examination, including gynae examination, the GP diagnoses postmenopausal bleeding. Or the bleeding cannot be, vaginal in origin. So according to the source of the bleeding, there can be sometimes rectal bleeding or bleeding from the urine. So a patient is coming to you, that may be, since it is coming from the vagina, so from the lower part of her body, so she thinks it is coming from vagina. So there can be other places where the bleeding is coming from. So you refer the patient to either, if it is hemorrhoids or something, rectal bleeding or urethral bleeding, then you refer to their specialties. Otherwise, postmenopausal bleeding is referred to the gynecologist. Okay, so what they are saying, GP referral, recurrent, if it is again and again coming, that this patient is having postmenopausal bleeding for 6 months. So she needs an urgent referral through the fast track pathway. Okay, so this is important. They expect you to ask the patient in this case that, okay, were you referred to within 2 weeks? So she will tell you yes. So this will, tell the examiners that yes, the urgency of the situation. You understand the case. Okay, then trial system, what they're saying, weekly or twice weekly review of the referral. Patients who meet the postmenopausal criteria are fast-tracked into the appointment system and given appointment within 28 days. Ambulatory gynecology, there's a one-stop clinic where they go at transvaginal ultrasound, and they can also do an office-based hysteroscopy and endometrial sampling, and patient can be discharged on the same day. Okay. Or if the patient is unable to finish all this thing in the one-stop clinic, then you have to send the patient to a hospital, and where it will be done under anesthesia. Okay, this is your end of the diagnostic pathway, that endometrial cancer ruled out with normal endometrium on hysteroscopy or negative endometrial biopsy. Then patient is diagnosed with either patient is diagnosed with the cancer or patient is not diagnosed with the cancer. So patient is diagnosed with the cancer, you send the patient to the oncology unit. If the patient is diagnosed not with the cancer, only endometrial hyperplasia, then the gynae people will take care of her. Okay. Then what else they are saying? Okay, somebody has a question. Unable to see? Kindly zoom. Okay. All right. How to zoom this one? It is there in the guideline. I don't know if I will be able to zoom this one or no. Wait, give me a little time. Okay. Okay, let's complete this. This is then we will try to make it zoom. I think I don't have the option. All right, we'll come to it later. So what they were saying, that this part is the diagnostic part finished over here. Okay, and then if the patient is having bleeding from the vagina and patient is on sequential hormone replacement therapy, which is increasing, the bleeding has increased in amount and it is becoming heavier, irregular. So accordingly, you will, after 6 months, you have to send the patient to this pathway, the pathway we discussed. That is early referral, triad system, transvaginal ultrasound on a hysteroscopy, and then according to the hysteroscopy and biopsy finding, you will refer the patient either to the gynae to continue treatment with the intrauterine device Mirena, or with the oncology unit if she is having some cancers. Okay, is it clear? Wait,
Yes,
I will
ma'am.
just go to the main RCPI site and I will show you from there the enlarged picture. Just give me 1 minute, please. See, can you see the screen now? Yeah. Okay. So I think it is more visible and it is large. More zoom. Still unable to see? Yes, you can see. All right. Thank you very much. All right. So as you see, this was the quick summary of the new guideline. I think what is new that we learned over here, because, you know, this is not like before our CPI was not making such type of guidelines with the referral pathway, time mentioned and all these things. So whenever they are mentioning something in a new guideline, they expect you to remember and answer the same in the exam. Okay, so once you are sitting in front of the examiner and they ask you that the patient is on HRT and she's having bleeding, so what you will do now? So what they expect from you to say? Anybody has any idea? We just saw this one, no? Come on. This is what we are discussing. Hello? Can you hear me?
Yes, doctor, we can hear you.
Yes, we can.
So, yeah. So what do you think? What they expect you to say?
So first, I will ask the patient since how long you have been taking this HRT and how you are taking it, and accordingly, I will decide.
Yeah. So what is that accordingly? If she is just started the HRT, now this is her second month and she's having abnormal bleeding. So what you will tell her?
Reassure.
Exactly. Very good. And now if she has crossed 6 months and the reassurance is not working, so what you will do now?
I tell her to follow up. If bleeding continue, to come after 6 months.
Yeah, now it is 6 months now. She has again come to you. She is saying that, doctor, you told me to wait. I'm still bleeding. What should I do now?
I will do ultrasound, abdominal ultrasound to see the endometrial thickness. TVS.
Abdominal
Transvaginal.
ultrasound? No,
Transvaginal.
abdominal.
TVS.
Transvaginal
TVS.
ultrasound, yes. Abdominal ultrasound you will only do to complement the findings of the vaginal ultrasound. Your investigation will be a transvaginal ultrasound, okay?
Yes.
So what you will do? You will do a transvaginal ultrasound, and what else can be done in the one-stop clinic?
we will see the endometrial thickness. If it is more than 7, we will do BBL biopsy.
Not
Oh,
7, what
officers.
we discussed, more than 4.
Hysteroscopy. More than 4.
More
This
than
one
4, not
tamoxifen.
7. More
This
than
one
4.
taking for tamoxifen also
Sorry?
more than 4. For
For
tamoxifen more
tamoxifen,
than
it is
4.
5, but otherwise it is more than 4. Okay?
Okay, so after that we will do hysteroscopy and biopsy.
Yeah, exactly. And hysteroscopy biopsy comes to be hyperplasia, atypical hyperplasia. What will be your plan of action?
Myrina.
Marina. What else? If a patient is postmenopausal, you just want to give Marina?
If the patient postmenopausal, postmenopausal bleeding, we will do we will take sample. If it is hyperplasia with without atypia, we will do without atypia Myrina. With atypia, we will do hysterectomy.
Yes.
Plus
If
bilateral salpingo.
Sorry?
Plus bilateral salpingo-oophorectomy. Hysterectomy and bilateral salpingo-oophorectomy.
Exactly. So if a patient is postmenopausal with atypical hyperplasia, you will offer her the definitive treatment, which is a total abdominal hysterectomy with bilateral salpingo-oophorectomy. And before that, if you're suspecting anything else like a spread of the cancer, then you have to investigate her. What further investigations you will need in a patient who is suspected, highly suspicion of endometrial cancer?
We will do CA125 tumor marker, chest X-ray, CT.
Yeah. And what else?
CT scan.
What uterus is close to? Which other organ immediately in front of the uterus? What is there?
We'll do KUB or
Cystoscopy. Yes.
cystoscopy.
KUB, cystoscopy, these all things, because maybe there is already some kidney involvement is there, so there is some hydronephrosis. So in cases of postmenopausal bleeding, it's very important that you should know this one classification of the endometrial carcinoma, okay? Because they will tell you once it is done, they don't expect you to do a specialized stuff. So, but at least the early stage cancers, how to follow, what is the follow-up plan, you should know that, okay? Clear?
Yes, clear, doctor.
All right. So basically, what we learned today in this updated guideline, I don't think there is something different from RCOG or from the previous guideline. Only the endometrial thickness, you have to be sure that it is more than 4 millimeter, and a patient who is postmenopausal, she has no bleeding and the endometrial thickness is 11 millimeter. This needs investigation. So remember this 4 and 11, bleeding and not bleeding. Then patient on HRT and patient on tamoxifen with abnormal uterine bleeding, they have to be investigated. Okay? I think it is a short guideline. This was just a summary of the guideline. So anybody has any questions regarding this postmenopausal bleeding or the MRCPI OSCE exam itself?
Ma'am, what will be the endometrial thickness if woman is taking HRT postmenopausal?
HRT, you see here, they haven't mentioned the HRT. They have just mentioned more than 4 millimeter, okay? But RCOG mentions about HRT and tamoxifen 4, 5 and all this. So if you're in a RCPI exam and they have given you already an updated guideline, so you just stick with the 4 millimeter thing. Okay, so they have clearly mentioned here 4 millimeter with bleeding, 11 millimeter without bleeding. This needs to be investigated.
Okay, ma'am.
Understood?
Thank you.
Welcome, no problem. Because I've seen the examiners and RCPI, if there's something already there in the RCPI, then they don't like you to talk about the RCOG guideline. Yes, if there is not something which is updated in RCPI and there's another version, they expect you to talk about RCOG, the updated things. But this is a recent guideline. They have mentioned something, just to speak about their guideline. Okay.
Okay,
All
doctor, I
right.
have a question, please.
Yeah, please.
Okay, so for the postmenopausal women who are taking HRT and endometrium is 11, so I should immediately refer to the fast track or what? I didn't get
Yes.
this point.
Yeah, you should refer her to the fast track unit, the 2-week pathway. If ambulatory gynecology clinic is available within 28 days, that is not available, fast track pathway.
And it's the same if it's 4 millimeter or no?
It is the same. 11 millimeter without bleeding, send her to further investigation. More than 4 millimeter with bleeding, send her for further investigation.
Okay. So 4 millimeter without bleeding, more than 4 millimeter without bleeding, reassuring?
What you are saying, I didn't get your question.
Okay, if the postmenopausal woman on routine examination, I check the endometrial sampling and it's more 4 millimeter, but she has no complaint, she has no bleeding.
No, but this is the thing. Why she's coming to you then? For what you are doing her endometrial, this one, ultrasound?
Maybe it's accidentally discovered, like...
Okay. It's still what they mean to say that you need to investigate a female whose endometrial thickness is more than 4 millimeters. She is postmenopausal.
Okay, so what further should I do for her if she is more than 4?
Biopsy.
Oh,
okay. Endometrial sampling you need to do. Okay?
Okay, thank you, though.
No problem. Okay. Anyone else has any question regarding the exam, OSCE exam? Please expect stations from the recent updated guidelines, okay? Because they will definitely be following their own guidelines since they have updated these things. So what guidelines were updated recently were, all right, yeah, here. So stress urinary incontinence was updated. Then there is complications and management with patients with mesh complications. Pelvic organ prolapse is updated. Placenta accreta spectrum is updated. Postpartum hemorrhage is updated. And postmenopausal bleeding. Then investigation and management of early termination of pregnancy, recurrent miscarriages, fetal anomaly ultrasound, stillbirth, vaginal birth after cesarean, early onset GBS. These all are updated versions, okay? So expect these in the exam. Okay, anybody has any question?
Doctor, can you please post all these updated guidelines to the group?
Yeah, okay. We have this MRCPI OSCE group and we post the updated topics for the 2023. Anyways, if you go to the RCPI site, it is all available there. But still, I will post it for you people on the MRCPI OSCE group. Okay?
Okay, thank you so much.
Welcome, no problem. So I think if you people don't have any questions, so let's call it a day. And if anybody of you who is going for the OSCE exam and they are interested in joining our course, it will be 6 to 7 sessions, a long course where we will be covering all the previous exam questions. And a daily, there's a discussion of daily topics, different topics. So we cover almost 80, 85 stations, which are all from the previous exams in our group. So if you people, anybody is interested, they can contact our technical team. Okay, in our sessions, we cover 2 long cases and 5 OSCE stations in each session. So there's a lot of practice chance for each person, and we don't take many people.
Sorry, please, what's the cost?
Sorry?
The cost of the course.
Cost, I don't know really. You have to speak with the technical team. They will just, guide you about the cost. Okay, Cynthia? I can only tell you my part, which is how we do the session. Each session, we are doing 2 long cases and 5 OSCE stations, so that you are well prepared for the exam day. And Alhamdulillah, we have a pass rate of 100%. So far, whoever took our course, they all passed the exam. Maybe somebody deferred the exam, but the people who sat in the exam, they all passed. Okay?